In the name of God, we have again another specific connective tissue, bone. Bone with prefix of osteo. When add to any word is related to the bone. For example, osteocyte means the cell of bone. The purpose of this lecture is at the end of this lecture, the student will be able to explain the function of the bone, mention the bone component, explain the future of bone cells and matrix, and also they can identify different types of bone within the human body. They can identify different types of joint within the human body. First, start with the function of the bone. You know, the bones bearing our weight because they make our skeletons. Because the bone make a solid material in our body, they can support or protect the vital organs in our body, for example, like brain, like lung, heart, all of these supported by these solid materials. And also, you know, the bone function as the ion reservoir or minerals or mineral material reservoir in our body, so our body can release, restore ions or minerals and in this tissue, of course, by a controlling way, by controlling manner. Another function of the bone is blood formation, because we have a bone marrow within the bone, and at the end the muscle attached to the bone and use bone as a lever to multiply the force produced by a muscle contraction, and by this way facilitate our movement. Bone, like other tissues, formed by two components, cell and matrix, but unlike the other tissue, bone matrix have a two portion, organic materials and inorganic materials, 50%. Organic material in the bones, because the connective tissue is composed of fiber and ground substance. Most common part and abundant part of organic portion of the matrix is collagen fiber, especially very thick fiber, collagen type 1. It makes 90% of bone matrix. Of course, the organic material. We have also somehow ground substance, hyaluronic acid, very little, proteoglycan, and glycoprotein. The glycoprotein in the bone is very important. The name of the glycoprotein is osteopontin, osteocalcin, and osteonectin. I will explain the function of this glycoprotein in the next slides. And in inorganic portion or inorganic materials, or called minerals, mostly we have the calcium and phosphate. These minerals together make a hydroxyapatite crystals within the bone, and we have also a little amount of other ions like bicarbonate, citrate, magnesium, potassium, and also the sodium within the bone. If I magnify this part again, we have organic material, inorganic material. Organic material is mostly formed by fibers and a little by ground substance. Inorganic material is also we have mostly calcium phosphate in the form of hydroxyapatite crystal. You can see the crystal of hydroxyapatite in the bone with this formula, and other ions. start with the bone cells. Like other connective tissue, this bone tissue is originated from the mesenchymal tissue. The mesenchymal cells differentiated to the osteogenic cell. They are precursor progenitor cells in the bone. Then these cells differentiated again to the osteoblast, and osteoblasts start to produce the bone matrix, entrapped, enclosed within the bone matrix, and create osteocyte. So this cell produce the bone matrix, and osteocytes entrapped within the bone matrix just maintain the bone matrix. The other cells is osteoclast. You see this cell is very large and multinucleated cells. This condition is due to this cells originated from the several monocyte. Monocytes, if you remember, in the connective tissue create a macrophage, but here these cells in the bone, these cells fuse together and make a huge and large cell called osteoclast. The osteoclast is responsible for bone resorption. So these cells break down the bone, destroy the bone, and these cells produce and maintain, keep the bone. We have a small piece of bone in this slide. We can see the osteoblast, osteoclast on the bone surface, but osteocyte within the bone. Like cartilage, here we again have a lacuna. In each lacuna we have one osteocyte. So osteocyte singly located within each lacuna, entrapped within the matrix, embedded in the matrix. But osteoblast and I said osteoclast we have in the bone surface. But when we see the osteoblast cells, we see these cells in two states. Some place you can see the cells, these cells have a cuboidal or columnar shape, and some place they have a squamous. And when we have a cuboidal cells, under these cells we have a yellow, somehow we can say the yellow bright line called osteoid or newly formed matrix. Osteoid means oid means similar, osteo means bone, similar to the bone. It is a newly formed matrix produced by the osteoblast cells. Why don't we call it the bone matrix? Because this bone is mostly formed by organic material, and we don't have enough inorganic material or mineral on this matrix, so-called newly formed matrix or osteoid. From this part we can result it when we have a cuboidal or columnar cells, these cells are active osteoblast, and when we have a squamous cells, it means these cells are inactive, and you can see we don't have underlying of these cells osteoid, so these cells are inactive cells. So we can recognize by the biopsy of the bone, we can recognize which parts we have an active osteoblast or active bone formation, and which part we have inactive osteoblast or we don't have bone formations. Here you can see after destroying the bone by osteoclast, the inactive osteoblast in a squamous shape get activated, get cuboidal, and start to form a new bone in a defected area. And after completion of the, or after repairing of defected area, again get a squamous form and get inactive. And usually we have this circulation or this cycle in the bone. Here we have a real sample biopsy from the bone, so you can recognize which part we have a bone formation from the shape of the osteoblast, cuboidal cells, this part, and this part you can see we have a squamous cell. We don't have bone formation in this part. The mechanism of calcification, why the calcium deposit on the bone? We have at least three reasons for that. The first reason is the collagen type 1, but collagen type 1 plus glycoproteins. Collagen type 1 is very susceptible to deposit the mineral material when we have a bone glycoprotein like osteocalcin and osteopontin. This glycoprotein increase the calcium and phosphate, especially the calcium concentration locally, and make it susceptible to deposition of these ions on a matrix. Another reason are matrix vesicle, I will explain next slide, and alkaline phosphatase. Let's see in this part. You can see the bone matrix, newly formed bone or osteoid, and active osteoblast. Permanently osteoblast produce a vesicle, and this vesicle release into the matrix, so-called the matrix vesicle. When we magnify this vesicle, you can see in this slide, we magnify one of the matrix vesicles. We see a lot of enzyme, alkaline phosphatase, on the cell membrane, on the membrane of this vesicle. This enzyme remove a phosphate group, so phosphate from the organic materials, from the other macromolecules, and release the phosphate. Then the phosphate by the other channels or proteins and again the membrane, surface membrane of this matrix vesicle, and transferred into this vesicle. From the other side you can see other protein send the calcium inside of the matrix vesicle. With high concentration of the calcium and phosphate within this matrix vesicle, these ions start to produce hydroxyapatite crystals within this matrix vesicle, and then by adding a lot of phosphate and calcium, these crystals start to grow, and by filling the inside of the matrix start to rupture the membrane, and outcrossing of these crystals or hydroxyapatite crystals, and at the end this vesicle filled by crystals and fuse with the other crystals and make a confluent mass of calcified material in the bone matrix. So the matrix vesicle serve as a center for a hydroxyapatite formation, for the start of hydroxyapatite formation. Again, here you can see the osteoblast release the matrix vesicle. Within the matrix vesicle you can see start of hydroxyapatite formation, and then rupturing the membrane and outcrossing and attaching all of these crystals together and make a confluent mass of calcified materials and deposit on organic materials, especially the collagens. If I back again in this slide, you can see outgrowing of hydroxyapatite crystals, increasing the number of them, and attaching the hydroxyapatite filled vesicle and make a confluent mass of mineral materials or calcified materials. The next cell is osteocyte. So up to here we understand osteoblast permanently produce the organic materials of the matrix and manage to the position of or to deposit of the calcified materials on disorganic materials. Then osteoblast entrapped within the matrix and make a osteocyte. You can see the osteocyte cells. These cells have a lot of extension cytoplasmic process. You can see a real picture also from these cells with a lot of cell process, and each of these cell process or this extension located within a very, very tiny canal called canalicles. You can see one of them. Each of these canalicule contain one cell process of these cells. Again, here you can see a CN picture from the two osteocytes with a lot of process located within the canalicules. You can see here the canalicule and the cell process within these canalicles. And also by light microscope you can see many osteocytes with a lot of cell process, or we can say canalicles. Why the osteocyte have a lot of cell extensions? This picture shows us why the cell have a lot of cell process. We have a two blood cell here, and as you know, because in the bone we have a mineralized matrix, so we don't have any diffusion of materials. So the cell nourishment happens that doesn't happen by diffusion. So for solving this problem, the osteocyte give a lot of cell process, this extension. Some of cells, they are close to the blood vessels, give the nutrient or take the nutrients from the blood vessels and transfers this material, these nutrients, to the other cells, again by this process, the cell process. So the cells, osteocyte, have a gap junction with the other osteocyte. They can transfer the material from cell to cells. So we can say we have a diffusion here, but cell to cell, not in the within the matrix. And one cell can nourish up to 15 cells around the cells nearby, the cells surrounding this cell. For example, this cell can nourish all of these cells because the cells have a gap junction with all of these cells. So this cell can nourish other cells. You can see here again we have a 3 lacuna. This lacuna attached together by a canaliculi. You can see this canaliculi. In addition to cell diffusions, we have also a little diffusion by these canaliculi. And in the next part, near to this part, you can see the canaliculi and the lacuna filled by a osteocyte and osteocyte process. And here you can see osteocyte, the process, they have a gap junction with each other. Again, here you see blood vessel, nearby cell give some process near to the blood vessel, take the materials, nutrients from the blood vessels, then transfers to the other cells by the extension or cell process and the gap junction with other cells. In this slide you can see the fate of or show us how osteoprogenitor cell differentiated to the osteoblast and then to the osteocyte. For example, start from this cell, osteoprogenitor cells differentiated and converted to the osteoblast. Osteoblast start to produce osteoid, but before completely entrapped by the matrix, you can see the start to give some extension. Again, here you can see give some extension and make a gap junction with the other cells and start to enclosing by the bone matrix, and at the end you can see it completely these cells entrapped by the bone matrix, but these cells have a now gap junction with the other cells. And in the last slide you can see after completion of bone formation, the osteocyte entrapped completely in the bone matrix and the surface osteoblasts get inactive and forming bone lining cells. The inactive osteoblasts on this bone surface called bone lining cell. Usually these cells and also the other osteoblasts, active osteoblasts, have gap junctions and have a electron junction with each other on the bone surface. It seems the osteoblasts within the lacuna, especially they are a single within each lacuna, it seems they are very inactive cells, but they produce a lot of cytokines factor, and these factor affect other cells of the bone, I mean the osteoblast and osteoclast, through the paracrine and endocrine way, affect them and manage and also they regulate the function of the other bones. For example, here you can see osteocyte by producing one factor called sclerostin stop bone formation by osteoblasts and convert them to the lining cells. Without secretion of this factor, you can see the osteoblasts start to get active and produce new bone in this world. So these cells manage the bone formation, and because all of them have a gap junction to each other within the bone, function as a mechanostat or mechanosensor. Actually, this mechanosensor detect mechanical load, mechanical stress, and also the fatigue that create the microfracture. This microfracture detected by these mechanosensors. For example, if you exercise, you put a pressure on your bones, and this pressure creates a stress on your bone. So these cells detect this stress, and in response, these cells produce a factor and activated the osteoblast. And osteoblast start to form a new bone with high density. This high density bone is very resistant to any fracture. So you can see the cells can detect stress and cause the other cells response to this stress. Here we have a slide show us something about the labeling of new form bone by a tetracycline. You know, the tetracycline is the antibiotic. By chance, the scientists understand this antibiotic is also fluorescent. This antibiotic has fluorescent molecules. We can see this fluorescency under the UV microscope or under the fluorescent microscope. 2 days, and the scientists use tetracycline labeling in the bone biopsy for measuring the rate of bone formation. It's very important parameter to diagnose some bone disorder. In this technique, you can see the physician administered twice of the tetracycline to patients with an intervening interval of 11 to 14 days. And after 14 days, take a biopsy from the bones, and the doctor or physician can understand this patient have a bone formation or not. How they can, you can see in for example in the disc biopsy, when the patient take the first injection of tetracycline start to deposit on a newly formed bone, on the osteoid part. The tetracycline make a complex with calcium and deposit on a newly formed bone, and under the microscope give a bright line like this. Then we give an interval, 14 days interval, then inject the next tetracycline, and again the tetracycline deposit on a newly formed bone. We have another bright line. By distance of this bright line, we can understand the rate of bone growth. For example, here you can see when we have a very close line, bright line, it means we have a very low rate of the bone. And when we have a very distant line, it means we have a high rate of bone growth. And when we don't have any line, it means we don't have any bone formation. For example, here you can see in this part we don't have bone formation, just in this part we have a bone formation. And the last cell of the bone is osteoclast. These cells destroy the bone and manage bone remodeling. Usually remove the old bone, then the old bone replaced by a new bone by the cell osteoblast. Now we want to know how this cell can resorb the bone or destroy the bone. At first, these cells firmly attached to the bone. You can see here we have a bone matrix. These cells firmly attached to the bone. The attaching area called sealing zone. Let's show the sealing zone by another slide. I think the osteoclast attached to the bone like this ball when you put on the page. You can see this part of this ball have a close attachment with a page like a osteoclast, and then make a hole, make a depression in the middle part. This part in the cell called subcellular packet or subcellular microenvironment depression. This part attaching to the, for example, the page or in the osteoclast in the bone called sealing zone. Then we have a section from the osteoclast like this. You can see sealing zone, that means the attaching part, and subcellular pocket. In the subcellular pocket, then the osteoclast start to increase the cell surface by folding, called a ruffled border. Let's back again to this slide. Sealing zone, for attaching to the bone, making a subcellular packet and ruffled border. Why the cell want to increase the cell surface? The answer is here. You can see within the cytoplasm of this cell, CO2 plus the water make a carbonic acid. Then carbonic acid converted to the proton ions and bicarbonate ions. Then the cells pump the proton ions and chloride ions to the subcellular pocket, to subcellular microenvironment, and make a HCl, hydrochloric acid. And the acid is a good solution for the calcification. So this acid here, they calcify the bone, remove the mineral part of matrix. Then from the other side, the cell secrete the lysosome enzyme. You know, the other cells usually store the lysosome enzyme as a vesicle inside of the cytoplasm. But unlike that cells, the osteoclasts secrete the lysosome enzyme by exocytosis into this microenvironment. And also, you know, this enzyme activated in an acidic medium, acidic microenvironment. So this enzyme start to digest the organic part of matrix. So the cells remove the organic part by this enzyme, lysosome enzyme, and inorganic portion by a HCl. Then transfer the calcium phosphate to the blood and increase the concentration of these ions within the blood. By this way, cell can resorb the bone. Again, here you can see the one osteoclast, multinucleated, and ruffled border for increasing the cell surface and increasing number of the proton pump, chloride pump on the cell surface. When the cells absorb or resorb the bone, make a depression on this bone surface. This depression, that cell located in this depression called hoe-shaped lacuna. This lacuna created by the osteoclast by itself. You can see a real picture from the bone formation by the osteoblast from this side, and bone resorption, bone and destroying by a osteoclast from other side. You can see a lot of osteoclasts in this part. We can recognize this cell with a lot of nuclei inside of these cells. For example, here you can see we have 5 nuclei within these cells, and also these cells are very huge and large cells. By electron microscope, you can see one osteoclast within the lacuna, hoe-shaped lacuna. And also you can see destroying the bone in the lab on the dish by osteoclast. This will start to destroy the bone, and you can see go ahead. I said usually to the student, the cells function like this animal, mole. Start to digging the ground and make a hole from one side and go out from the other sides, like these cells. Start to destroy the bone from one side and comes out from the other side. The formation of the osteoclast regulate by the osteoblast. Osteoblast produce 2 factors MCSF, monocyte colony stimulating factor, and rank ligand. It's the acronym for this big name. It's not important. By the first factor, MCSF, osteoblasts cause proliferation of monocytes. After proliferation by this factor, then we have a receptor on the monocytes, cause fusion of monocytes together, differentiate and make you osteoclast. In this slide again you can see osteoblasts produce MCSF, cause proliferation of monocyte, then by a rank ligand cause fusion of the monocytes and make a osteoclast. Also, the bone cells have a function or have a metabolic role in the bone. For example, here you can see the calcium hemostasis or calcium concentration in the blood. In the normal situation, we have about 9 to 11 milligram in 100 ml. When we have a decrement, we have a falling in the calcium concentration in the blood. This decrement detected by a gland, foregland in our body called parathyroid glands. Then this gland produce a hormone called PTH, parathyroid or parathyroid hormone. PTH has a receptor on osteoblast. Affected osteoblast, then osteoblast produce two factors, make osteoclast, produce osteoclast. Osteoclast destroy, resorb the bone and release the calcium and phosphate into the bone, into the blood, and you can see the range of the calcium back to the normal. And when we have a rising in the blood, in a calcium concentration in the blood, in this time the thyroid gland detect this rising, detect this increment, and produce calcitonin. Then calcitonin function in two ways. The first way, inactive osteoclasts and convert them again to the monocytes. So we don't have a bone resorption and releasing of calcium into the blood. And from the other side, stimulate calcium deposition in the bone, so decrease the calcium within the blood. And again we have back to normal concentrations. So by this way you can see these cells have a metabolic role in the bone. And here we have one of bone disorder called osteopetrosis. Osteopetrosis is a genetic disorder. This patient is characterized by a dense and heavy bone called marble bone, stone bone. This is also. In these patients, we have just bone formation without bone resorption. So because of that, we have a heavy and dense bone. This bone formation filled also the bone marrow cavity and destroy bone formation, decrease the bone formation, cause the anemia. You can see the normal bone and osteopetrosis bone. Why we don't have a bone resorption? Because we have a defect or non-functioning osteoclast in these patients. You can see the normal osteoclast and the affected osteoclast. These cells doesn't have ruffled border. The cells cannot produce the proton pump, ion channel, chloride channels. So they cannot resorb the bone and we have just bone formation. This bone formation causes the outgrowing of the bone, and this outgrowing causes the deformity of the skeleton. You can see this deformity in the skeleton.